Well, hello everybody, and welcome to another virtual CME activity webinar of IAVA cardio risk waves. I think this is wave number 9. Today's waves is supported by educational grant from Janssen Company. I would like to thank them. I would like also to thank the ICOM company for the technical support. Our subject today is a very interesting subject, actually. We will discussing with eminent speakers the issue of pulmonary arterial hypertension. And the message we wanted to deliver is that pulmonary arterial hypertension is different from pulmonary hypertension. You have to know by the end of this presentations the types of pulmonary hypertension. What is the meaning of pulmonary arterial hypertension? Is it a specific category of pulmonary hypertension? Should we treat it differently? What is the category of patient having pulmonary arterial hypertension? Why we are interested in pulmonary arterial hypertension? Is it a serious disease or not? I hope in the discussion we can clarify this issue. And let me present to you this case. I will not discuss the detail of the case, but just look with me for this case presentation that you may find in your clinic. 34-year-old woman who developed dyspnea during her second pregnancy and was diagnosed as pulmonary arterial hypertension following delivery in December 2005. Her mother had died at the age of 32 with pulmonary arterial hypertension. Maternal grandfather died at the age of 30, and an uncle has also died. So this is a clinical scenario you may face. What type of disease is that, and how can we approach in the diagnosis and management? In January 2006, she developed dyspnea of function class 3, meaning that the dyspnea became more severe. She did cardiac catheterization. The right atrial pressure was 5, pulmonary arterial pressure 67/30, mean 45, pulmonary capillary wedge pressure, and as you know, pulmonary capillary wedge pressure is a reflection of the left ventricular end diastolic pressure, and it is 9. She is on intravenous treprostinil. We will know during the next presentation about some pathways and some drug therapy for this issue. In April 2006, she did a 6-minute walk, and they added Pozintan to the treatment. And August 2006, her 6-minute walk was 549. Please unmute the mic, all of you. Sildenafil was added, and she was listed for transplant. Look at this case scenario and be with us to understand the issue of pulmonary arterial hypertension and all its aspects. Actually, I'd like to thank Janssen for their educational support to our program. Today, Dr. Nabil Farag has some emergency, and he will not be with us. And I asked Dr. Ahmed Shawqi and Dr. Muhammad Salim to try to cover the issue of screening and diagnosis during their presentation, and we'll try to highlight this issue, giving some more minutes to each presentations to highlight the issue. So let me first, after a 30-second break, to introduce Professor Ahmed Shawqi for the first presentation. So stay with us. We'll take a 30-second of break. Thank you. Welcome back again, and I have the honor to introduce one of the executive member of the board of IAVA, Professor Ahmed Shawqi Sarafi, Professor of Cardiology at Shams University. And as I told you, he will talk to you about the management strategy, in addition to highlighting some issues on the diagnosis that would be covered by Nabil Farag, and we are waiting to this presentation of very interesting subject. Dr. Shawqi, Fadl.
Thank you, Professor Ashraf. Always a pleasure to be part of your very educative ideas and sessions. Thank you, Janssen, for sponsoring this. Thank you, ICOM. Actually, pulmonary hypertension is an entity by itself, and we are always not looking at this diagnosis. And of course, it's a serious condition, and mortality and morbidity is quite high. Not only the mortality, but also morbidity, hospitalization, and death rates are quite high in this disease. So correct diagnosis is the most important part, because it goes along with a lot of diseases. It could be similar to patients with heart failure. It could be similar to patients with chronic obstructive airway disease. And the problem is not a correct diagnosis will not help us manage the patients very well. Second of all, we're going to take a look at the recommended pathways, because there are some new definitions for pulmonary arterial hypertension that we should understand. And this is quite important to understand that there is a difference between now and the guidelines that were published in 2015. And pulmonary hypertension, note here, it has been changed. It was 25 or more millimeters of mercury in the increase in the mean arterial pressure. Now, it is a mean pulmonary arterial pressure of 20 millimeters mercury. This is according to the World Congress on Pulmonary Arterial Hypertension. And just like electricity, when we're talking about the resistance and the velocity, we're talking about, of course, the flow of blood and its affection. And watch out that the mean pulmonary arterial pressure, which is only accurately measured by right heart catheterization, has so many things that can interchange it, like the pulmonary arterial wedge pressure, like Professor Ashraf was just discussing, the cardiac output, and the peripheral resistance. So we can have an elevation of the mean pulmonary artery in left-sided heart failure or left-sided valvular diseases, or in cardiac output elevation, like hyperdynamic situations like exercise, or in pulmonary vascular resistance elevation. So this is quite important, that the definition is not 25 now, it's 20. And there are anatomical differences. What do we mean anatomical differences? And this is important for the diagnosis. We have what is called the pre-capillary pulmonary hypertension. That is to say, the pulmonary hypertension that is occurring before the capillaries. It is not because of a left-sided problem. And this is seen in the clinical groups 1, 3, 4, and 5, and we will tell you what they mean. But what happens here? The mean pulmonary artery pressure is above 20. The pulmonary arterial wedge pressure is below 15. So this is a case not related really to the lungs or to the heart. Post-capillary is when you have a mean arterial pressure of the pulmonary arteries above 20 and the pulmonary wedge pressure above 15. And this is very common in left-sided heart failure and in lung diseases or some miscellaneous problems, mainly miscellaneous, sorry, it's not the lung. And sometimes we have a combination. Sometimes a patient may start off with a left-sided heart failure with a post-capillary pulmonary hypertension and then develops a pre-capillary pulmonary hypertension, and this occurs in left-sided diseases also, and also in miscellaneous parts. So this is quite important to understand, that the hemodynamics are very important to understand. But looking at the most important, the pulmonary hypertension as an entity, as you see here in the light purple, the pre-capillary pulmonary hypertension constitutes around maybe just above half of it, and the pulmonary arterial hypertension that we're talking about, the idiopathic and the hereditary, actually are quite low. And this is what we call the WHO Group 1 classification. So yes, you might think that yes, and it's true, that pulmonary arterial hypertension, which is the idiopathic or hereditary, is quite uncommon. Yes, it's not so common. But pulmonary hypertension as a disease entity is very common, actually. So we're not just looking at the disease entity by itself, we're looking at several problems. And what is this group 1? The WHO actually put the pulmonary hypertension into 5 groups. Group 1 includes pulmonary arterial hypertension, the idiopathic, which is seen a lot in young females, the hereditary, those related to toxins, connective tissue disorders, also congenital heart disease. And in our country, there is a data from Aswan Heart Center that shows, and also from Cairo University, that shows a lot of our pulmonary arterial hypertension may be related to bilharzia and schistosomiasis. This is really important. And also pulmonary arterial hypertension with overt capillary and venous diseases, and sometimes also seen in the newborn, which is the persistent pulmonary hypertension. So actually there's a lot. Of course, don't forget the portal pulmonary hypertension seen in hepatic diseases and the HIV, which is the HIV virus. So these are all part of group 1. So when we're talking about treatment of group 1, actually, we're not talking about the idiopathic or hereditary. We're talking about indication for all medications in all of these diseases. It is possible. And actually, it is complex in its pathology. It's not just vasoconstriction of the vessels. There is endothelial dysfunction, vascular smooth muscle proliferation, and then thrombosis. And this was a part when there was an indication for giving anticoagulation. Actually, this is not so much important right now. But there is inflammation, and there is a pathology in the capillaries and the microvessels of the bronchia. This leads to an increase in pressure across the pulmonary arteries and thus the right ventricle. The right ventricle, just like systemic hypertension, will go to the left ventricle, will have the same results of the left ventricle, remodeling, then hypertrophy and failure. And this helps a neurohormonal activation, increasing the remodeling again, and this causes more and more problems and failure and more dilatation, and this gives us a vicious circle. So sometimes in the end, the pulmonary artery pressure is a little bit controlled, but the symptoms are there, the edema is there because that the right ventricle has failed. The other 4 groups are simple. There is group 2, which is any problem due to left heart disease. And actually, now they have a classification that heart failure due to reduced, due to preserved, valvular, or acquired cardiovascular conditions. So reduced ejection fraction is important. So does preserved ejection fraction. And I'll give you a hint how important it is to diagnose this condition in pulmonary arterial hypertension, in pulmonary hypertension. Group 3, it's simple. Again, lung diseases that causes hypoxia, like obstructive or restrictive lung diseases. Number 4 is one of the commonest seen in now in the COVID era, which is chronic thromboembolic. And 5, which is called the miscellaneous or unclear, like some hematological disorders, like some metabolic disorders, like some complex congenital disorders. So there are a lot, and you can see in the table below, there are lots and lots of numbers. So it's 1, which is the pulmonary arterial hypertension, 2, left heart disease, 3, the lungs, 4, the chronic thromboembolic, and 5, the miscellaneous. How to diagnose? Of course, what is the commonest thing that is used? Of course, the echo. Symptoms, like Professor Ashraf was talking about, there's a lot of dyspnea, there's a lot of right-sided failure in advanced cases, but actually the symptoms are very vague. Echo is really important because it gives us a hint. Mind you, echo does not measure the mean arterial blood pressure of the pulmonary arteries. It measures the peak tricuspid also, and this is added to the right atrial pressure, which gives us the right ventricular systolic pressure. But an accurate measurement of the right of the pulmonary artery pressure, the mean pulmonary artery pressure, is through right heart catheterization. There are also other signs like the septal shift or a D sign that we see here in the lower part. The left ventricle is compressed by the dilated and hypertrophied and very significantly pressured right ventricle. Also, we can see a lot of changes in the right atrium. We can see some pericardial effusion, but definitely, of course, when you see a right atrium and right ventricle which are dilated, as seen here, this could denote a pulmonary hypertension. But right heart catheterization, as said by the guidelines, is necessary in nearly all cases. I'm not going to say it's going to be done in all cases because this should be done in pulmonary hypertension referral centers, and we'll give a hint about that at the end. Here is the only part of the investigating with which we can actually measure the mean pulmonary artery pressure accurately, get oxygen saturations, calculate the vascular resistance, and this will help us to isolate, is this pre-capillary, post-capillary, or combined? So again, diagnosis includes one, the symptoms and signs, which are usually most are vague. The echo is seen a lot, the right heart catheterization, and of course, looking for other causes and looking for secondary causes like left ventricle and lung diseases. The WHO has a functional status like Professor Ashraf was discussing in his case. There's class 1 to class 4 according to the amount of symptoms, according to the amount of exercise. But we have to know that actually pulmonary arterial hypertension has a significant impact on the patients. It has a very significant impact in more than half of the patients. So this is an important thing. Patients are going to be very ill. Patients are going to not work as good as they are, and their physicality is reduced. And when we risk stratify the patients, it's not only the symptoms, the right ventricle, but the exercise tolerance, again, as shown by Professor Ashraf, how long a patient can walk. This is a 6-minute walk test, which is extremely important. And of course, the hemodynamics, the higher the pressure, the worse the prognosis. So there are so many doing fine. This patient is an intermediate risk. This patient is a high risk, and this is really important for us to help our control of the patients. There are so many risk scores for that, but the most collective is called the REVEAL risk score. It has a lot of data or variables, as we say, like the subgroup of the WHO functional classification, some demography about the age, if there's a systolic blood pressure below 110, if there's a right atrial pressure above 20, the 6-minute walk test, the heart rate, if we have an elevation in the natriuretic peptides, which is also important, if there are hospitalizations within the last 6 months, and the renal function, a lot. But actually, it has the most of predictive value. There are other scores which are more simple, but this is the most collectively seen risk score and has a lot to do. The higher your score, the worse the prognosis, the less the survival. So this is really important to risk stratify your patients. The French registry, on the other hand, has a very simple 4 criteria, which is the WHO or NIHA classification, which is a functional classification. The 6-minute walk test, if we have a 6-minute walk test above 440 meters, which is good, below 160, which is bad, the right atrial pressure, and the cardiac index. But actually, if we look at all the guidelines and even the World Congress on Pulmonary Arterial Hypertension, they have 3 categories: the low risk, the intermediate risk, and the high risk. The low risk is patients who have a class 1 or 2 functional classification. They have severe or moderate exertion dyspnea, not mild or rest like stage 4. Their 6-minute walk test is above 440, not below 165. Their N-terminal pro-BNP levels are quite low, not high like is seen in the high risk. The right atrial area and pressures are fine, are less than 8 and less than 18 centimeters squared on the very high risk or the high risk. We see a right atrial pressure above 14 and a cardiac index below 2. So there are a lot of parameters. And looking at the patient in which risk category, this will lead you to help yourself how to manage. And this is extremely important in pulmonary arterial hypertension. Because number one, there should be an improvement of the functional class, because this has shown to improve outcomes in patients. Not only better symptoms, but better prognosis. And it is the treatment goals seen by the physicians. If you look at the patients, they want the same. They want to feel better with a better survival and improve their functional status. Also, an important part about pulmonary hypertension is that there is hospitalization. And if you have a patient with hospitalization, there is worse outcomes. And reduction of hospitalization by medications improves outcomes. This is important also. So let's take a look on the management strategy in the 5 groups of pulmonary hypertension. First of all, diagnose. If you suspect, you might look at something else. For example, If we look at the whole world, what is the most common phenotype of pulmonary hypertension? It's a little bit different, but very commonly, there is a left-sided heart disease. Again, lung diseases are very common. So this is extremely important. And if you remind yourselves from the WHO classification, the number one in the left ventricular ejection fraction is the preserved ejection fraction failure, not the reduced ejection fraction failure. And here, there is a score inside the World Symposium of Pulmonary Hypertension on how to diagnose left-sided diseases, especially in the preserved ejection fraction, which again is a mysterious disease and is overlooked a lot. You have to look. The older we are, the more factors we are, the atrial fibrillation, structural left ventricular disease without an impairment of ejection fraction all lead to the diagnosis of heart failure with preserved ejection fraction. Again, if you have a case that you suspect there is thromboembolic pulmonary embolism, you might be very important to diagnose these patients because this is a potentially curable form of pulmonary hypertension. Patients that have been bedridden, patients that have a history of DVT, maybe if we diagnose this very quick, and here the cornerstone of diagnosis is the ventilation perfusion scan, not just the CT pulmonary arteries, the ventilation perfusion scan. So we diagnosed our patients. What do we have as treatment options? Let's talk about group 1, which is the WHO group 1, which is the pulmonary arterial hypertension. Very simply, we have 3 medical pathways: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And I will discuss this and give you an explanation. But there are also adjunctive therapies. If the patient is edematous, diuretics. Sometimes we used to give a lot of warfarin and anticoagulants. Actually, there is no much more benefit seen now in the guidelines, the updated World Congress of Pulmonary Hypertension. Digoxin shows very little data, and also heart failure medical therapy or guideline-directed medical therapy is related mainly to the heart failure. Does it affect a lot the pulmonary arterial hypertension? Not so much, but definitely improves the heart failure. And these are the guidelines published in 2015. But here, importantly, I would like to just put a stress that in the general treatment measures, please, if the patient has pulmonary arterial hypertension, it is preferred that he or she gets influenza and pneumococcal vaccination whenever possible. And if the patient is probably going to get pregnant, this is avoided as much as possible because it's very deleterious. This is the most important slide. There is a paradigm shift in the medical therapy now. If you have a low or intermediate risk patient, you're going to give medications. Very few patients will receive monotherapy, and a lot of data now on the initial oral combination therapy, just like hypertension. We start with 2 medications, and I will discuss this quickly with you. If the patient is high risk, there is an initial combination, including intravenous prostacyclin analogs, which is important. Then we look at the patient after 3 to 6 months according to the symptoms. If the patient has gone to the low risk, this is perfect. This is just a follow-up. If the patient's still in the intermediate or high risk, then we up titrate to triple therapy, and then we might even consider lung transplant. So this is really important. So it's according to the risk, and it's starting now, most of the recommendations is with dual therapy. And what therapies are we talking about? If we understand this slide, we'll understand the therapies as simple as possible. We said we have 3 targets: the endothelin pathway, and we know endothelin is one of the most important and potent vasoconstrictors. And there are 3 medications that can inhibit it. The oldest is bosentan, there's ambrisentan, and the most, with the least side effects, or the newest is the macitentan. We have the nitric oxide, and nitric oxide is a very potent vasodilator. There are 2 pathways to managing this. There is the phosphodiesterase inhibitor, phosphodiesterase enzyme, which causes degradation of this nitric oxide, and inhibition of this enzyme really helps out. Or if we have a cyclic GMP cyclase stimulator that increases the cyclic GMP, any stimulator like here riociguat really benefits and increases the nitric oxide. The third thing is the prostacyclins, and we know the prostacyclins are very potent also vasodilators, and they work through adenylate cyclase, and there are oral, inhaled, intravenous medications for these. So it's the three. Endothelin, in the middle is nitric oxide, and the prostacyclin on the right. And actually, there are so many medications, and usually one important thing is that you don't combine the same medications from the same group. This is really important because you will not have any extra benefit from that. And their indications are here. But we'll take a quick look at the data and the randomized control studies to what we got nowadays. There were studies on monotherapy, as you see in black. A lot of studies on sequential drug does not give enough. Or there are some on dual combination from the start. This is sequential combination when adding a second drug, and this till 2015 was actually the guidelines. Try a monotherapy, then add a second therapy. Try an endothelin receptor antagonist and add, for example, sildenafil or tadalafil or even riociguat. Or start with riociguat and add macitentan, for example. And this has shown improvement. But actually, there was another trial that showed the benefit of that, which is the initial combination therapy. It was called the Ambition. They tried monotherapy and then addition or combination therapy from the start. And here they used an endothelin receptor antagonist and a phosphodiesterase inhibitor. And the data showed definite improvement of events, which was significant. And this is why you might read the latest guidelines, which are 2015, and they talk about sequential or monotherapy, but the newer updated data from the World Congress of Pulmonary Arterial Hypertension talk of a lot of the times initial combination therapy from the start. And combination therapy, you put an endothelin receptor antagonist with a guanylate cyclase stimulator or endothelin receptor antagonist with a phosphodiesterase. Only in the severe cases with the very high risk, you might start with intravenous prostacyclin analogs. And these are just the drugs and their classification and how they were added to each other. Very few indications for monotherapy in the newest of the guidelines or the newest of data in the very, very fragile patients, in the very early patients which have mild, very mild hypertension, or in those which is, of course, not a medical actually indication, is when you don't have an available medication or there is contraindication, as for example, in severe liver disease, you cannot give certain endothelin receptor antagonists. Again, I remind you, this is the slide. What we are trying to do is lower the risk and manage the patients, because the end result of pulmonary arterial hypertension, if it's not well treated, if the patient's not doing well, if the patient's still a high risk, is lung transplantation. And remember how to assess the patient when he's coming back. His intermediate or low risk or high risk is really a lot of data, and it is a very simple chart. You can keep it in your smartphones or on your desk. And the American College of Cardiology actually published a few months ago just a simple 6-minute points that you should look at all patients to assess the risk and their follow-up, instead of the extensive WHO chart that we saw. Of course, there are indications of lung transplant in certain cases. Referral, it's meaning that already the patient might go to a pulmonary hypertension excellence center and might be thinking of that, but the listing is that the patient is really requiring a lung transplant, and this is in the severest of cases. A quick look at the other groups. Group 2, we said it's left ventricular disease. Treat the left ventricular disease. So that's so simple. No problem. Group 3, which is due to the lung disease, treatment of the lung disease. This is mainly a chest physician, but there are few data on other medications, and treprostinil actually showed a data very recently published and presented in the conference ATS just a couple of months ago, improving the 6-minute walk test. Riociguat did not show that. So in treatment of type 3, treatment of the underlying disease of the lung, and there are data to show treprostinil, which is a prostacyclin analog, may help. 4, which is a problem in the thromboembolic pulmonary hypertension. Of course, avoidance of a DVT follow-up, that's very good. But actually, if you have pulmonary hypertension due to STEP, as they call it, which is chronic thromboembolic pulmonary hypertension, endarterectomy, but of course, very few centers are doing it. Here in Egypt, I think it's Aswan Heart Center. And sometimes very distal, if you have the lesions, beaded lesions, especially in the pulmonary tree, there is balloon pulmonary angioplasty, which can be done. And these were included in the guidelines 2015 and reinstated in 2019 in the update of the WHO. There are data on risegwat in chronic thromboembolic that shows a little bit of improvement. Treprostinil also shows very recent data that it can improve. And even macitentan, the endothelin receptor antagonist, that shows in that there are better outcomes, especially in the patient status, in giving these with chronic thromboembolic. But the mainstay, if the patient is in severe cases, of course, the patient might undergo embolectomy. Of course, the rare diseases, it's according to the rare diseases, and this is important to take into consideration. What is the disease and how to manage it, which is group 5. Finally, where do we do this? And this is an important thing. Since 2015, there is always a recommendation of a pulmonary hypertension referral center, and this is a multi-professional team. It's not a cardiologist, it's a cardiologist, respiratory physician, a radiologist, a psychologist, and all a multidisciplinary approach, because the patient has a lot of problems. And this is important. We have some referral centers, I know in Aswan, I know in the Cairo University, in the National Heart Institute, and this is really helping out patients much more and more. So I'm sorry to take a little bit of your time, but I had to give a little bit on the discussion of the diagnosis. Diagnosis is paramount of the disease itself, because it might be vague, we might think it's another disease, but also knowing which class of disease or which group of the disease will help us manage the patients correctly. And now we're talking about 2019. Most of cases, I'm not going to say all cases, are going to have an initial combination therapy, be it an endothelin receptor antagonist with a nitric oxide donor, let's say that, or a prostacyclin analog. Adjunctive therapy, of course, is always there. If you have edema, give diuretics, but warfarin as anticoagulation, the data is poor and should be used minimally. And we should understand that the obstacles of treatment of those in non-group 1, like group 2 and others, is that they might end up having more and more, especially group 2, they might have a pre-capillary, post-capillary, and all of that. So actually, the best thing is to diagnose, manage early, and follow up your patients very regularly. Thank you.
Thank you, Ahmed. Actually, a very interesting subject. And I'm sure Dr. Salim will give more elaborations on the treatment and drug therapy and the others. I want to highlight the issue of definition again. So you wanted to tell us that when a patient have heart failure and he developed pulmonary hypertension, this is not what we mean by pulmonary arterial hypertension. This is just back pressure from the left heart to the pulmonary venous and pulmonary capillaries, reflecting on increasing the pulmonary artery pressure. So increasing the pulmonary arterial pressure, or the pulmonary pressure, in itself is not an indication, is not telling us that this is pulmonary arterial hypertension.
Exactly.
Pulmonary arterial hypertension started with the pathology in the arterial system, in the arteries of the lung, not the pathology in the lung, not pathology in the heart failure or the valve. My question to you, if we have heart failure or lung disease or whatever cause of the non-group 1 pulmonary hypertension, could this end with pulmonary arterial hypertension?
Yes, especially the left lung, left heart disease. Yes, they can end up with having persistent pulmonary arterial hypertension even after the medication. this is what we call post-capillary becoming pre-capillary, and this is a very big problem. And this is what we said in the that there are sometimes crossover from left-sided heart failure to becoming pulmonary arterial hypertension, which again, thank you so much for elaborating. It is a disease entity by itself. It's not related to the heart or lungs, but it can, yes.
So in this stage, to diagnose pulmonary arterial hypertension, it is very important to not only depending on the level of the pulmonary arterial pressure. We should assess the pulmonary vascular resistance. So if you have high pulmonary pressure and high pulmonary vascular resistance, this means that you have pulmonary arterial hypertension. My question here is that, could we use this new drug therapy in a case of, for example, Cor Pulmonale, who developed increased pulmonary arterial vascular resistance and pulmonary arterial hypertension, or heart failure, who developed later on pulmonary arterial hypertension?
You can use it in congenital heart disease, but complex congenital or heart failure with a reduced ejection fraction has been not studied till now, or there are no recommendations for it. But in congenital heart disease, yes, you can use them.
Tamer, any questions?
I'd like to ask طبعا congenital بس ما عدا الايزنمنج use it up to to severe pulmonary hypertension, but we couldn't use it as a major to reverse.
There is a problem in the net. النت فيه مشكلة. دكتور عاطف أو عندك سؤال؟
دكتور أشرف. I'd like to say hello to everybody. I was watching my dear Professor Ahmed Shawqi, and I'd like to ask him. We know that the pulmonary arterial hypertension is a prothrombotic state, and you mentioned that the anticoagulation. Would you recommend the anticoagulation, oral anticoagulation from the start with the other treatment of pulmonary arterial hypertension, and not to wait, because it's a prothrombotic state, you know? So we should wait, yes, or we should start early with the DOACs, for example.
The data on warfarin, mainly it was warfarin, and it was given in 2015 a class 2B recommendation. It was not a very good recommendation. But now, even with the 2019 updates from the World Congress of Pulmonary Hypertension, I'm not going to say a grade because they are not guidelines, but they are saying the benefit are less and less. Is it contraindicated? No. It's according to your patient. If you have a feeling that a lot might die from in situ thrombosis, yes, you might write it. But the benefit seen with warfarin and the mortality benefit is not there. Benefit from symptoms is not there. So it's a postulation, part of the pathogenesis, but maybe the antithrombotic medication so far has not been adjusted, or the INR is not adjusted, or use of NOACs. Actually, we don't know about that data.
And for the index separatory mean pulmonary artery pressure, as Dr. Ashraf said, and the PAP and the pulmonary wedge pressure, which one of these you should depend on?
Perfect. Diagnosis of pulmonary hypertension, whatever the cause, is the mean pulmonary arterial pressure, and this is most accurately measured, or nearly always better measured, through the right heart catheterization, especially in a patient that you want to diagnose. Not only in the right heart catheterization will you measure the mean pulmonary arterial pressure, you can have the wedge pressure, you can do the pulmonary vascular resistance that Professor Ashraf was talking about, because the pulmonary vascular resistance is higher in the precapillary and lower in the postcapillary. So you will not only diagnose what is it, you will also diagnose what is the problem. It might be a postcapillary, like the left ventricle functions, like Professor Ashraf, especially in a patient with heart failure with preserved ejection fraction. He has a normal ejection fraction, but pulmonary hypertension, and this is an entity which helps us which is the right heart catheterization.
Thank you, Ahmed.
Thank you, sir.
Welcome, Dr. Sayed. Welcome to
Dr. Sayed.
Hi.
I have small question for Dr. Ahmed, Dr. Ashraf.
Okay, go ahead.
Dr. Ahmed, you elegantly come through the diagnosis and the treatment of pulmonary hypertension. But here I want to ask you about the cutoff value of the mean pulmonary artery pressure and pulmonary artery systolic pressure. You know, pulmonary hypertension is one of the criteria for diagnosis of HFpEF, heart failure with preserved ejection fraction. But here, the cutoff value of the pulmonary artery pressure is different from the cutoff value of the pulmonary hypertension in group 1. You mentioned the mean arterial blood pressure should be more than 20 millimeter mercury.
Yes.
But here in HFpEF, the cutoff value written in the scores for HFpEF is the pulmonary artery systolic pressure and not the mean pressure. And it should be more than 35 millimeter mercury. What do you think about this? Why there is some sort of difference in the cutoff value?
A very good question. If you look at, I think it's around the way they diagnose. First of all, HFpEF is mainly an echo diagnosis, and it's not just the diagnosis by the standard echo. You do a lot, the E over E prime, and the left atrial dimensions, the left ventricular structure, the left ventricular volumes, the Doppler wave, and also pulmonary hypertension is important. But the pulmonary, the elevation of the mean pulmonary artery above 25, which was deleterious, the data now suggests that 20 itself is as deleterious as 25. 20 to 25 used to be the borderline. So we're talking about two diseases. Mean pulmonary artery, which is best diagnosed by right heart catheterization, which is mandated in pulmonary hypertension, that's the way. Echo diagnosis of pulmonary increased pressure, the right ventricular systolic pressure. In HFpEF, this is a score yes, and I loved your lecture on the diagnosis, Professor Salim. It was lovely, thank you. So it's maybe because there are two different diseases and the two investigations used are different.
Okay,
thank you.
So I think we can, I am sure we'll have a lot of discussion after the Professor Salim presentation, which will be more elaborating the issue of the diagnosis and treatment modalities. So let me now take another 30-second break before the presentation of Dr. Salim. Welcome back again, and very interesting subject. I enjoyed very much the presentation of Professor Shawqi, and I'm sure we will enjoy together the presentation of Dr. Salim. Again, our message today is that pulmonary arterial hypertension is a specific category, specific disease category. And as I told you in the first, in the introduction, I gave you an example of a young female with severe pulmonary hypertension, with dyspnea. She may got into lung transplant if you could not detect and risk stratify early and start treatment that may help her. Let us look at this presentation about the innovation in pulmonary arterial hypertension management. Professor Mohammed Salim, National Heart Institute, Egypt. Dr. Salim, tfadl.
Thank you, Professor Ashraf. It's always my pleasure and honor to be part of the IAVA continuous scientific activities and very interesting waves. And today we have, I want to say it is a little bit forgotten disease from us. Although we are diagnosing those patients with a mean delay of at least 2 years. 2 years delay in the diagnosis of the pulmonary arterial hypertension or PH. And at diagnosis, unfortunately, the majority of patients are classified as intermediate risk with a 1-year mortality of 5 to 10%. If we will classify patients into low risk, intermediate risk, high risk, and we will come here to the figure of the mortality over 5 years, we will find that the low risk patients, after 5 years, the survival rate is about 76%, In intermediate risk patients, it is about 52%, and in high risk patients, it is a very low survival rate, less than the heart failure with reduced ejection fraction. And here are the three columns. Most of the patients at the diagnosis, we will find them at intermediate risk or high risk, and only minority of patients less than 15% of low risk category. And again, I will come through this slide, which Dr. Ahmed Shawqi come through it, and I will repeat it again to stress or underscore the importance of the goals of our treatment in pulmonary hypertension. If we will classify the risk less than 5% or between 5 and 10% as an intermediate one and more than 10% as a high risk group, we need from our patients to be less symptomatic, less clinical signs of heart failure. The functional class will be much better with low risk, less syncope, less progression of symptoms, very important. And one of the most important prognostication tool or prognostic tool in those patients, which is the 6-minute walk distance. Ideally, in patients with PAH, it should be more than 440 meters. In intermediate risk, it is somewhere between 165 to 440, and if it is less than 165 meters, those patients are high risk, and simply those patients who will walk less will have higher mortality. Also, the functional status of the patient could be assessed by the cardiopulmonary exercise test, and ideally we coming through treatment to make the peak oxygen consumption above 15 ml per minute per kilograms. And also one of the goals of the treatment to come from high risk patients to low risk patients is normalization of the biomarkers or decrease their level across the treatment course, and also improvement in the right side heart functions. And this could be assessed either by the reduction of the right atrial area, which is a reflection of the RV and the diastolic pressure, or even a hemodynamic parameter to decrease the right atrial pressure less than 8 and increasing the cardiac index about 2.5 liter per minute per square meter. Here is the goal of the treatment to improve patients' risk status, as lower risk, as I have just mentioned, is associated with better survival. And for any patient, whatever the treatment, is it traditional treatment, classic treatment, innovative treatment in the field of pulmonary hypertension, these are the risk variables that should be assessed in any patient with pulmonary hypertension, which is the WHO functional class, 6-minute walk distance, biomarkers, BNP and NT-proBNP, right atrial pressure, cardiac index, and mixed oxygen venous saturation, which should be ideally above 65. Despite treatment in the past 2 decades of pulmonary hypertension, almost around 60% of patients were considered to be at intermediate risk at follow-up. And those patients constitute a very high group for developing mortality. I would classify my lecture into 2 parts. Part number 1, which is the innovative treatment in the past 10 years regarding the medical treatment. Unfortunately, most of these innovative treatments, simply they are taking orally, and they avoiding some sophisticated technique in the past for giving a continuous intravenous infusion of prostacyclin analogs and other complex regimen, which put a lot of burden for the patient and for the health care provider. Here we have the main 3 pathways for PH or pulmonary arterial hypertension. If we can successfully and effectively inhibit this pathway, which is the endothelin pathway, through what's called ERA or endothelin receptor antagonist, and if we can succeed to stimulate this pathway, which is a nitric oxide pathway, and we have 2 categories here. If we can go to stimulate this soluble guanylate cyclase and increase the GMP, we can induce strong vasodilation and improvement of the pulmonary remodeling, which is an important pathogenic mechanism in the progression of pulmonary arterial hypertension. And here, this is a new class or innovative class of medications represented by what's called ribosegwit, which is a soluble guanylate cyclase stimulator that will increase the GMP production. Meanwhile, we have a traditional treatment, which is the phosphodiesterase inhibitor 5, which will inhibit this enzyme, represented mainly by the prototype sildenafil, and also they will increase the GMP and will increase the sensitivity of nitric oxide and its effect on the endothelium, and also will lead to vasodilatation and the anti-proliferative effect. The last pathway, which is the most complicated one, however, it's the most potent pathway, which is the prostacyclin pathway. We remained for more than 20 years acting on what's called prostacyclin analogs. And most of the prostacyclin analogs, unfortunately, they have very short half-life, so it should be given continuously through subcutaneous or intravenous pump, either external or internally implanted, and with a potential risk of infection, venous thrombosis, and difficult in application and delivery. But the breakthrough or innovative treatment in this pathway is the development of prostacyclin receptor agonist, and I will come through this one, which is a very important innovative pathway. So remember this: by inhibition of the endothelin, by stimulation of the nitric oxide pathway, and by stimulation of the prostacyclin pathway, most recently by the selective prostacyclin receptor agonist, we can change dramatically the natural history and the improvement of the bad outcome of patients with pulmonary arterial hypertension. And also the evolving of the treatment over the past 25 years is starting from monotherapy, then sequential dual combination, and then initial dual combination, and then risk-oriented sequential, even triple combination from the beginning that will improve the risk status. A lower risk is associated with better long-term patients' outcome, decreased hospitalization, and decreased mortality. Also, morbidity and mortality endpoints have emerged as the new standard in clinical trials in PH. Previously, only the functional assessment and the clinical trials focused on short-term functional improvements, for example, 6-minute walk distance. But in recent years, the focus has shifted to achieve long-term morbidity and mortality endpoints reflected by the survival figures and reflected by the hospitalization rate. I will come to my first line of medical treatment, which is called the Selexipag, or its generic name Uptravi by Johnson & Johnson. It's a very effective oral treatment for pulmonary arterial hypertension. And Uptravi or Selexipag is a selective oral prostacyclin receptor agonist. And Uptravi or Selexipag has higher selectivity for this receptor versus other prostacyclin analog. It is the only oral non-prostanoid receptor agonist proven to improve long-term outcomes in patients. And it receives FDA approval in 2015 and received European Medical Agency approval in 2016 after an important trial, which is called the Griffon trial. And this trial was the largest study ever in pulmonary arterial hypertension patients. It included more than 1,100 patients and studied over 4 years of follow-up. So Uptravi or Selexipag, which is the first of class oral prostacyclin receptor agonist, receiving FDA indication, and it is indicated according to FDA recommendations for the treatment of pulmonary arterial hypertension or the group 1 of pulmonary hypertension to delay disease progression and reduce the risk of hospitalization for pulmonary arterial hypertension. And also its effectiveness was established in improvement of the functional class in those patients, and patient group included not only idiopathic or heritable forms of pulmonary arterial hypertension, but also in patients with connective tissue disease disease-related pulmonary hypertension like scleroderma, and also in patients with congenital heart disease, pulmonary associated hypertension, in which the Eisenmenger syndrome, making the prognosis of those patients is almost fatal. The same for EMA indication like FDA indication, but they stated also that it could be monotherapy or could be a combination therapy or triple therapy added to other classes from different pathways. If we will come to the SEX Working Society of Pulmonary Hypertension in 2018, recommend adding Uptravi or Selexipag in intermediate risk patients, and treatment should be intensified if there are still signs of intermediate risk at follow-up. When the initial treatment approach results in an intermediate risk status, escalation to triple combination therapy is recommended, and this is a general rule in any class of medication, not only here. And for patients with intermediate risk status on double combination therapy, the addition of Selexipag or Uptravi has the highest recommendation and evidence, and for the first time speaking about outcome trial with decrease in hospitalization and decrease of the hard points of mortality. This is the Griffon trial, which including primary endpoint regarding the disease progression or hospitalization or any sign of treatment failure like initiation of parenteral prostanoid therapy or chronic oxygen therapy, or need for lung transplantation or balloon atrial septostomy, or mortality. All these primary endpoints were assessed in this phase 3 Griffon trial, which included more than 1,100 patients or more than 1,000 patients, and the Uptravi was used in incremental doses starting from 200 BID up to 1,600 microgram BID. And as you see here in Griffon trial, most patients were on background therapy. About 80% of those patients included in this study and given Selexipag or Uptravi has a background therapy, either ERA or endothelin receptor antagonist plus phosphodiesterase 5 inhibitors. And almost nearly half of patients were in the functional class 2 and was classified as at least intermediate risk. And a range of disease subgroup in this trial for the first time, including PAH from different etiology in group 1 of pulmonary hypertension, about 30% of them connective tissue disease related pulmonary hypertension, and almost around 10% with congenital heart disease, a little bit less than 60% idiopathic or heritable form, and only 3% from other etiology like toxin, drugs, HIV, and others. This is the finding of Griffon study. Griffon showed that Uptravi reduces the risk of morbidity and mortality endpoints in a broad range of patients, irrespective of background therapy. It attained 40% risk reduction, and it was highly statistically significant, consistent with the primary endpoint. Uptravi reduced the risk of morbidity and mortality events, and almost in connective tissue disease-related pulmonary hypertension by 41%, and in congenital heart disease-related pulmonary hypertension about 42% relative risk reduction. And this is the comparison in this trial or subgroup analysis in patients receiving background therapy. As I mentioned, it's almost 80% of patients receiving ERA or BDE5 inhibitors, and we will find that there is an almost addition of 37% risk reduction if we will add Uptravi to double therapy to become a triple combination therapy. We can more and more 37% risk reduction. And the improvement in patients receiving Uptravi in addition to other treatment, there was a marked improvement in the WHO functional classification and a relative risk reduction of about 64% regarding this endpoint, and also it was statistically significant. What about the survival rates? For the first time, addition of medicine like Uptravi will increase the survival to approaching those patients with low risk patients. If you remember my first slide about the survival figure in low risk group, it was exactly like this. It's around 76%. So addition of selexipag will make the survival rate for all patients, including high risk and intermediate risk, to be in the same range of low risk patients, around 76%. And also this data from the Griffon study was supported by the real world evidence, because now it is estimated that all over the world, more than 10,000 patients receiving this excellent medicine for treatment of pulmonary hypertension. And it was estimated that about 85% of patients improved or maintained their risk status after 1 year of using selexipag, using the same risk stratification as I mentioned, including the functional class, the 6-minute walk distance, the biomarker, the right atrial pressure, the cardiac index, and the max oxygen venous saturation. And also titration of doses in this medicine, making the personalized dose of Uptravi in each patient, because you know that if we will coming to increase the dose in some patients, we can gain some side effects. The side effects here and the safety of selexipag in comparison to the same class old medications of prostacyclin analog are very minimal and are tolerable, and we can increasing the dose gradually, and if the patient cannot tolerate more, we can come to the previous dose. It is important to explain that side effects are expected, and the goal is to reach the maximally tolerated dose of Uptravi or selexipag. If side effects are not tolerable, however, dose is reduced by 1 step, coming downgraded, and this represents the patient's what's called patient's personalized maintenance dose. Here is some of the side effects related to the prostacyclin, because although it is a selective oral prostacyclin receptor analog, potentially it has some side effects which is not significant if compared with placebo, like GIT symptoms, like some headache, like pain in the jaw, like myalgia and muscle pain, like flushing, dizziness, arthralgia, temporomandibular joint syndrome, and all of these medications in clinical practice can be controlled by some antidiarrheal, antiemetic, and anti-nausea, or some analgesics, but in most of the patients, they can tolerate these medications for life. If we will come to the second pathway, which is the endothelin receptor antagonism pathway, we have 3 main classes of this. We have the old one, which is the bosentan. We have the second generation of the ambrisentan, and the last one, which is the macitentan or Opsumit. And here, by the old one, which is the bosentan and the other one, we can have some unmet needs associated with ambrisentan and bosentan. There is an increased risk of edema as monotherapy and in combination therapy with phosphodiesterase inhibitor 5. And also, no demonstrated survival benefit with the old generation of this class, ambrisentan and bosentan, and these limitations were markedly improved by the new one, because the new one, which is the macitentan, we have a very high affinity for the endothelin receptor antagonism, and also macitentan demonstrates a sustained blockage of the action of endothelin in both types of receptors, endothelin A and the endothelin B receptor antagonist. Macitentan can penetrate deeply into tissue because it is lipophilic, and compared with other bosentan and ambrisentan, macitentan and its metabolite have a longer half-life, which supports once daily dosing. Also, macitentan has less drug-drug interaction, and there is no hepatotoxic effect in comparison to bosentan. Here is the comparison. We have what's called Seraphim trial, and the Seraphim trial also included a good number of patients in the trial of pulmonary hypertension. If you come here to compare the number of patients in this trial of macitentan, we will find it is exceeding 700 compared to other trials. It's a good number, and also for the first time from this class, it is an outcome trial including time to the first occurrence of a morbidity and mortality event compared to other trials which the primary endpoint of them were only the functional assessment or 6-minute change in the 6-minute walk distance. Here is the results of this trial. Macitentan significantly reduced the risk of morbidity and mortality event in those patients. We have two dose regimen. If we will come to the 3 milligram compared to the placebo, we have a relative risk reduction of the primary endpoints about 30%. And if we come to the higher dose, 10 milligram, we have more incremental improvement in the outcome and significant reduction, relative risk reduction of about 45%. Not only that, but we will find that this beneficial effects in the mortality and morbidity will be evident from the beginning of therapy in the first 6 months. As you can see here very clearly that there is an early divergence of macitentan and placebo curve in favor of macitentan. And also the risk reduction of primary endpoint event versus placebo in patients with background pulmonary arterial hypertension therapy was also improved. If we will add macitentan to patients already receiving therapy for pulmonary arterial hypertension from other class, with 3 milligram, we can add 17% more relative risk reduction. And if we, in the higher dose regimen, we can attain around 38% relative risk reduction. And also, for the first time, macitentan is effective across the gender, functional class, and disease etiology in different subgroup analysis. Whatever the functional class, it is the same beneficial effect. Whatever the etiology of the group 1 of pulmonary hypertension, whether collagen vascular disease, congenital shunt, idiopathic, heritable form, we can attain the same comparable effective results. And also, there is no gender difference regarding the efficacy of the drug in improvement of the primary endpoint. And also, macitentan may offer a survival benefit. There is tendency and numerical decrease in the mortality and morbidity and hospitalization in patients receiving macitentan. However, this beneficial effect did not reach statistical significance, maybe due to the sample size or the study is only 742 patients. But if we can go for more recruitment, we can change this figure to a statistical significant difference. The third pathway, which is the nitric oxide pathway, both phosphodiesterase inhibitor 5 inhibitors and soluble guanylate cyclase stimulants or activator target the nitric oxide cyclic GMP pathway. And from a mechanistic point of view, this stimulator of the soluble guanylate cyclase may have several advantages over the PDE5 inhibitors like sildenafil. What are these advantages? Number one, the therapeutic action of PDE inhibitor is dependent on the baseline nitric oxide availability. Unfortunately, this nitric oxide availability is already reduced in PAH. In contrast, owing to its nitric oxide independent mode of action, stimulators of soluble guanylate cyclase are effective even when nitric oxide production is markedly reduced. And also, phosphodiesterase 5 inhibitors acts by prevention of cyclic GMP degradation. Accordingly, in disease where cyclic GMP levels are low, the effectiveness of this drug is expected to be markedly limited. And these stimulators of the guanylate cyclase can also not increasing the production of nitric oxide and cyclic GMP, but it can favorably sensitize the endothelium to the effect of already decreased level of nitric oxide. Here is the example or the typical prototype of this drug, which is the riosigwin. Here is a simple explanation of the action of the riosigwin. By stimulation of this guanylate cyclase, we can increase the cyclic GMP and we can induce vasorelaxation, decreasing the pulmonary artery pressure. Riosigwin increases the sensitivity of native soluble guanylate cyclase and directly stimulates the native enzyme independently of the level of nitric oxide. And both actions lead to vasodilatation and significant decrease of the pulmonary artery pressure. This was reflected in decreasing, marked improvement of the 6-minute walking distance in some pilot study early in this medications, and also the pulmonary arterial pressure and pulmonary vascular resistance were significantly decreased in those patients receiving riosigwin, and it is approved for riosigwin to be used in CTEPH or chronic thromboembolic pulmonary hypertension. As you can see here, a significant reduction of the pulmonary arterial pressure and decrease in the pulmonary vascular resistance in both pulmonary arterial hypertension and especially in the CTEPH in comparison to other arm of the study. And also here is the improvement in CTEPH or pulmonary arterial hypertension in the functional class, more patients coming from functional class 3 to functional 2 or functional 1. And also riosigwin has a strong evidence evident by the patent 1 and patent 2 study, which has an extension from the patent 1 study. It is called the pulmonary arterial hypertension stimulator of guanylate cyclase trial, and the primary outcome measures change from the baseline in 6-minute walk distance after 4 months, and secondary outcome measure change from the baseline in the pulmonary vascular resistance, a change in the WHO functional class, change in the biomarkers, and a change in the quality of life. And all of those were favorably improved in the arm receiving riosigwin. The conclusion for this medicine is that riosigwin, or this new class of drug, the stimulators of soluble guanylate cyclase, which will increase the cyclic GMP, significantly improve the 6-minute walk distance, as well as pulmonary vascular resistance and several other secondary efficacy endpoints in patients with symptomatic pulmonary arterial hypertension who were receiving no other treatment for the disease or who were receiving endothelin receptor antagonist or prostanoid. So it can be used either combined therapy or triple therapy. We will come to another innovative treatment after these 3 classic pathways in the medical management of pulmonary arterial hypertension. We have a new drug called bardoxolone methyl, and it was evaluated in pulmonary arterial hypertension, especially those in patients with connective tissue disease related pulmonary hypertension, as it will act about specific nuclear factor related receptor called nuclear erythroid related factor 2. They can activate this one and they can inhibit the nuclear factor kappa B, and hence they promote mitochondrial respiration and reduce the reactive oxygen species and inflammation. And unlike the other pulmonary arterial hypertension therapies, this drug, which is called bardoxolone methyl, directly improving mitochondrial function and energy production in skeletal muscle cells and does not influence systemic hemodynamics. And efficacy analysis suggests that bardoxolone methyl increased the 6-minute walk distance in pulmonary arterial hypertension patients, mainly in the patients with connective tissue disease-related pulmonary hypertension. And we have a trial called LARIAT, and this LARIAT study is expanding to study more the usefulness of this drug in pulmonary arterial hypertension when it is related to interstitial lung disease, or what's called group 3 pulmonary hypertension. And there is another phase 3 trial started from 2016 and is expected to finish by the end of next year to show the outcome of this bardoxolone methyl in patients with interstitial lung disease related pulmonary hypertension. Now, still in some patients, especially those pediatric age group and in resistant cases, we have an innovative treatment or an implantable pump device called Lenus Pro. This pump is implanted subcutaneously and is attached by a venous catheter to continuously deliver intravenous treprostinil, and the use of this Lenus Pro implantable pump resulting in significant subjective improvement of vitality and physical effect of heart-related quality of life with acceptable safety profile, and it is refilled every 1 to 2 months percutaneously through this port, and the patient can live with this pump, and it shows very promising results. Also, in patients with COPD-related pulmonary hypertension, we have this device called pulsed inhaled nitric oxide, and by pulsed inhaled nitric oxide, you can use this from 6 to 9 times per day to give the maximum flow rate of this potent vasodilator effect of the nitric oxide at the beginning of inspiration. So it will increase the vital capacity of the patient, and it will improve the aeration and the vasodilatation in many areas of the lung in those patients with COPD. And this is a very important and very innovative treatment, and we are waiting for the FDA approval of this nitric oxide inhaled pulse therapy in those patients with COPD. Also, the balloon pulmonary angioplasty for chronic thromboembolic pulmonary hypertension. Here we see that it is mainly indicated in those patients considered to be inoperable for pulmonary arterial endarterectomy, or with patients undergoing endarterectomy and still they have residual pulmonary hypertension. We can go for selective balloon pulmonary angioplasty, and if you see here, this area, there is no perfusion, and after pulmonary balloon angioplasty, you can see here improvement in the flow and the opening of these vessels in comparison to the upper left panel, and this also can be directed by IVUS, very new technology and very innovative technology. For this technique, balloon pulmonary arterial angioplasty, it is an alternative therapy in selected patients who have inoperable disease due to distal surgically inaccessible disease or persistent or recurrent pulmonary hypertension after thromboendarterectomy, and successful pulmonary angioplasty may reduce pulmonary artery pressure in patients with this disease, but we need more data and more trials to approve this medication as a beginning for those patients. Also, we have a very interesting technique that was presented for the first time in the TCT 2013, which is the pulmonary arterial denervation. They come to the bifurcation at the pulmonary and they making radiofrequency ablation, and it was said that ablation of this area will ablate or abolish the baroreceptors and marked decrease in the sympathetic nervous system afferent reflex here, with a resultant decrease in the pulmonary vascular resistance and improvement in the pulmonary artery pressure. And denervation in this first-in-man trial was associated with lower pulmonary artery pressure, mean and systolic, and it was statistically significant, improved 6-minute walk distance, and reduced biomarkers at the 3 months versus the baseline arm. However, you know that after a downgrading of the Simplicity trial and the denervation technique, there was no other trials regarding this technique, but I think now with more improvement in the technology, there are many pilot trials for pulmonary artery denervation in pulmonary arterial hypertension that we are expecting within the coming 2 years to see if this technique will be beneficial or not. We have also some methods for creating of adequate intra-arterial communication. This is a palliative technique just to decrease the pressure over the lungs. Of course, we have the old one, which is the balloon atrial septostomy, but we have also two innovative techniques. One of them is the implantation of fenestrated Amplatzer atrial septal occluder. As you see here, it is the one used in the exactly to occlude the ASD. However, it is fenestrated to make a counter effect, to make some sort of atrial shunt between the right atrium and left atrium and decreasing the pulmonary artery pressure. Also, we have a new technique, interatrial septum stenting. As you see here, we can use what's called diabolo shaped stent, and it could be balloon expandable one or a Palmas Genesis length 36 and mounted on a balloon and the diameter between 5 and 8. It is like the peripheral stent, and there are some case series in the literature with some favorable results, but we need more data about the feasibility of the technique and which patient will gain benefit from this one. You can see here, this is through the right heart cath and then making the stent implantation here. And here is the peripheral stent implantation without modification of the stent. And you can assess by echo the continuous flow from the right atrium to the left atrium and decrease of the right atrial pressure and right ventricular pressure, and then decrease of the pulmonary artery pressure. If we will come to take-home message, although pulmonary arterial hypertension is a complex, multifactorial, and fatal disease, the past decade has been marked by dramatic improvements in the management of patients with pulmonary arterial hypertension. Issues that require further elucidation include identification of patient populations who will most benefit from a particular therapy. And the answer of this question, which therapy for which patients, resides in the continuation of gains in our understanding of the disease pathophysiology, clinical experience, and additional investigations and trials of current and novel regimens. And in conclusion, as the therapeutic goals for patients with pulmonary arterial hypertension are increasingly met, improved disease awareness in conjunction with the availability of new and innovative therapies should lead to better long-term outcomes for patients with this fatal disease. And thank you for your attention.
Thank you, Salim. Actually, another interesting presentation. So I can understand now that most patients of primary pulmonary hypertension or arterial, of course, primary is part of the arterial pulmonary hypertension, not synonymous. Okay, most patients will be in the moderate risk group. Most patients will be encountered in the moderate risk group, and probably they will need combination therapy, as Dr. Shawky said, and as you confirmed, we'll need combination therapy. 2 or 3 pathways may be used for treating them. So how can we detect those patients earlier? How can we, whom should be screened for this important, serious, progressive disease, which is pulmonary arterial hypertension? Whom should be screened?
I think, Dr. Ashraf, as you said, the patient should be screened is the patient who is coming and presenting of symptoms suggestive of presence of pulmonary arterial hypertension. It is mainly shortness of breath, dyspnea, in the absence of other disease or pathophysiology that can explain this dyspnea. However, if the patient is presenting without risk factors, for example, for heart failure, and young female, for example, presenting with unexplained syncope and unexplained dyspnea, and even though the echo is the initial screening method, and still I have to suspect the presence of pulmonary hypertension, I can go further for hemodynamic assessment or even invasive hemodynamic assessment. But the patient with unexplained dyspnea should be come into screening for the presence of pulmonary arterial hypertension.
So after screening, if you find a case, now according to your presentation and presentation of Dr. Shawky, we have to do risk stratification or risk assessment or risk scoring for this case to see whether it is low risk, mild risk, or high risk. What is the best way or the best parameters used to assess the risk of a case of pulmonary arterial hypertension?
The risk assessment, number one is the functional class. This is number one. The second is the 6-minute walk distance is very important. It is ideal, should be somewhere between 380 and more than 440 ideally. And in the high risk group, if it is less than 165. The third is the RV functions and the presence also of some echocardiographic parameters of RV dysfunction, and even the presence of pericardial effusion, for example, is a high risk predictors in patients with pulmonary artery pressure. And also the high elevation of the biomarkers. Biomarkers are elevated and should be used in the assessment of the risk of the patients. All these factors together will decide which patient in low, intermediate, or high risk.
Any questions or comments?
Yes, Dr. Salim, I really enjoyed this very innovative lecture, and has also enjoyed the Professor Shawqi lecture. My question here is, first I have a comment, because as you mentioned, that the key step in the management of pulmonary hypertension strategies is the WHO function class. It's very important to determine, and also a very simple test which we all of us, or most of us, decline it, is the 6-minute walk test. So they are very important, the functional class. And my question here: what about the problem of renal impairment in those patients, liver impairment in those patients, for the currently used innovative drugs? Because most of those patients have some renal impairments, and others, of course, have some liver impairment. And also another questions, they are taking a cluster of drugs, diuretics, vasodilators. So there is any determined drug-drug interaction which we have to consider?
For hepatotoxicity, we have, that those patients presenting late usually have hepatic affection and renal impairment due to impairment of the RV function and low cardiac output state. We have to be very cautious, especially in some classes of drug. The most of them will affect the liver is the old generation of the endothelin receptor antagonist, which is the bosentan and ambrisentan. However, the macitentan has less hepatotoxic effect on these on the liver enzymes and liver functions generally. For the prostacyclin receptor analog, Uptravi or Selexipag, it is considered generally more safe on the liver. However, in severe renal impairment, it should not be given, because those patients will be very sensitive to even mild degree, because this drug also, those patients will be very sensitive to hypotension if I will give them this prostacyclin receptor analog. So in these cases, and I think these cases also is a candidate for heart-lung transplantation, not for oral treatment, because they are usually terminal with end organ failure.
Drug-drug interactions, is there any mentioned drug-drug interaction? Especially I have read in the literature that there is with Uptravi, there is some interaction with clopidogrel, for example.
Yes, because Uptravi is, I think it's metabolized in the pathway of the cytochrome B450, and it may have some interactions with some antiplatelets, and even with fibrates may have. Yeah, gemfibrozil, it can have some drug-drug interaction and can elevating the liver enzyme. So we have to be very cautious and reducing of the dose and close monitoring of the liver enzymes in such patients which are receiving both medications.
Thank you, Professor.
So I think for Ahmed Shawqi and Salim to wrap up, I will share with you the first 2 slides in the introduction, which is the case of the young lady. This is the case, and let us let me see your comment again on this case regarding the diagnosis, regarding the risk assessment, and the possible treatment strategy. Dr. Shawqi, this is the 34 years old female, developed dyspnea during her second pregnancy, has pulmonary arterial hypertension, family history of mortality of her mother, her grandfather, and her uncle. His catheterization results: right atrial pressure 5, pulmonary arterial pressure 67, mean 45, and the pulmonary vascular resistance 6. What do you think, Dr. Shawqi?
Very important. Like you just asked, it's a very good question, and Professor Said just told us. Her functional class is class 3. She's worse. She was not so bad. She's in the intermediate stage from the 6-minute walk test. So these are very two simple bedside tests, a 6-minute walk test and the WHO classification of the functional class. If you want to talk by data here suggests that we give initial combination therapy. Why was she given IV treprostinil as a prostacyclin analog? I'm not sure, because you usually start with an endothelin receptor antagonist and a combination with either a phosphodiesterase inhibitor or a riosigwat, which is a guanylate cyclase stimulator. Then, if the patient is not responding, yes, you can add the third group, which is the endothelin receptor, prostacyclin analogs, especially the IV, if it is severe. And she improved. The data now suggests start with initial combination therapy, up titrate to a third drug if the patient is not improving, like you just said. But I'm just wondering, the sequence of medications was a little different than the newest of data.
Okay. Any comment, Dr. Salim?
Yes, my comment here, first for the hemodynamic parameters, we are dealing with typical pre-capillary pulmonary arterial hypertension, because here the pulmonary vascular resistance is above 3. And also it is a heritable form. This is a heritable form of pulmonary arterial hypertension, because she has a strong family history of pulmonary arterial hypertension and sudden death of the grandfather and mother. And also here we have to be very cautious in ladies in the childbearing period if we will give them endothelin receptor antagonist, because they have very strong teratogenic effects. So this is my consideration here. We have to be very cautious in females in childbearing period to give this class of medications.
And what is the importance of the value of pulmonary capillary wedge pressure 9?
That is not,
yes.
This denotes, sorry, Dr. Muhammad. This denotes it's not a left ventricular heart failure.
Yes,
because it's not above 15. Sorry, Dr. Muhammad, I'm very sorry that I botched it.
So this is definitely pulmonary arterial hypertension case. And let me conclude with that. We wanted to highlight the message that pulmonary arterial hypertension is a specific group of disease. This is group 1 of classification of pulmonary hypertension. This is a relatively old classification, but we are still in the same domain. Group 1 pulmonary arterial hypertension, either idiopathic, familial, or associated with some disease like connective tissue disease, drugs, and toxins. And I want to highlight that this is very different from pulmonary hypertension due to left heart disease, or due to hypoxia, for example, or due to chronic thromboembolic pulmonary hypertension. And as Dr. Salim and Dr. Shawqi elaborated very elegantly, the 3 pathways of controlling the pulmonary vessels, and for each pathways we have a treatment for prostacyclin pathway, we have a treatment for nitric oxide pathway, and we have a treatment for endothelin pathway. So I think if there is no comments from my colleagues and the professors, I want to conclude this elegant scientific activity. And thank you, Professor Shawqi, Professor Salim, Dr. Atif Al-Bahari, Dr. Said Farag. Thank you for ICOM, and thank to Janssen. See you later. Thank you very much. Goodbye.
Thank you.